welcome everybody, dear colleagues, dear experts, and everybody who are interested in the e-health governance. I am Kerti Merimaa from Estonian Ministry of Social Affairs, and I am very happy to welcome you to our informative meeting. And thank you for being interested in the e-health governance topic. Today's session is the second one in series, and it's part of the activities planned to support the Estonian e-health governance model project, where we, with different Estonian health stakeholders, together with Minister of Social Affairs, Ernest Young, European Commission, and international experts from EHTEL, European Health Telematics Association, are collaborating to redefine the Estonian e-health governance and to renew its structure, processes, and KPIs. And as part of that, to design a more informed governance model, our colleagues from EHTEL have prepared overviews of e-health governance of 7 countries. Today, we will hear about the e-health governance in the Netherlands. And without further ado, I give word to Siim from Ernest Young. He can also say his welcoming words. Thank you.
Thank you, Kerti. The main idea of looking those country reviews is to gather some interesting lessons learned and information and pros and cons from different countries, their practices of e-health governance in order to utilize this experience in Estonian model.
So good afternoon, everybody. I think Netherlands is an excellent country to analyze. It's not an easy one to understand. And one thing people need to understand about the Netherlands is that basically there is a higher reluctance to over management by the state, or to management by the state in general. So the state has to do what is absolutely necessary, but refrain from engaging into too much management, direct management. So they have defined a number of legal acts which deal with social care, the health acts which need to be covered by the insurance, the public health aspects, the long-term care, and the social support. And they defined basically the overall rules in that law. And then it's up to the each of those systems to auto-regulate themselves, I would say. So it's a system extremely liberal in the spirit, I would say. There is a legal framework for the different workflows associated with this different segments of the healthcare of the health system, and then it's up to the people to do it. The role of the public bodies is more to, I would say, safeguard from a distance rather than managing it directly. So it indeed advise. It stimulates, it controls a number of aspects, but it refrains from managing directly. And here I've only listed a few arm's length independent agencies which are responsible for different things, but as you can see, they are not directly managing. They are evaluating technology, like the national care, the National Healthcare Institute, or they need to control that nobody is taking a leading role in the system. So again, it's very much in phase with the liberal vision of the system, or to ensure that the safety and accessibility of care is guaranteed, or to propose a number of studies or research which are important for the future of Dutch people, but it's mainly this safeguard or control then or advisory role than manager. It's important to keep in mind when looking at how they see the eHealth. It's not a very they have not drafted a very long basically action plan. They have a vision, but they try to summarize it to a number of important points, which are closely connected with the vision they have for the health of the future for their society. And that's what you see here. Of course, they agree that they need a basic infrastructure, but what they want to go towards is clearly to push telemedicine, to push people empowerment, to push new treatment supported by big data, and to keep people home as long as possible with the support of self-measurement. So that's basically what they want to work upon. So they define that. That's what the whole stakeholders should work around. And they link that just through and I will speak about it later, in the eHealth Information Council, which is in Holland the main governing body. They translated that into 4 priority objectives for now. And there is no real date for an update. I mean, it's a continuous update, I would say, but it's medication safety, focus on the patient. So standardization, information exchange, and on-time recording of data. That looks appealing, right? We will see that there are, although the Ministry of Health has indeed defined a number of high-level objectives, and both in terms of ambition and action, and has set up clear goals. 5 more years of life by 2040, 30% decrease of health disparities. And they say, now how can we help to reach that with eHealth? They stopped almost there, actually. In the eHealth system, the principle is just self-governance. National obligations are as rare as needed, I would say. So a strong resistance to any centralization of data and deployment of central systems. Dus if there is no centralization of data, you need interoperability. That's very clear. But this has been very much left to the field to get organized in order to reach that goal. They had, however, very early in the process, as early in 2008, deployed a central infrastructure for access to decentralized systems. So nobody even thought initially about centralizing data. That would not even be thinkable in Holland. But there was a central infrastructure for data, for access to decentralized system, and it was run by the Dutch National Competence Center, NICTIS. But when it came to legalize this infrastructure, so to make somewhat compulsory the use of that infrastructure, there's been a huge resistance and almost a revolution, which led to a very clear decision that the Ministry of Health had no more authority over ICT infrastructure development. In 2018, it was just decided that the sharing infrastructure had to be transferred to a private organization called VZBZ, which is representing basically all the clients of the health system. And furthermore, it's also institutionalized in a way the regionalization communication of the system. So adding, I would say, a level of complexity. Furthermore, there is a high sensitivity to privacy in Holland, and thus it was not agreed that the patient consent for sharing data would be obtained through an opt-out system, but rather through an opt-in, and that has been also a main problem in order for the system to grow. Nevertheless, the Netherlands have a very high degree of digitalization, one of the highest of Europe. But the reality is that this high level of digitalization coexists with different networks which work in parallel, are not always compatible, and are not always are sometimes also supporting the same goals. Since 2015, as I said, the focus on the patient and the patient health record has been very much the central point of attention, but also because of lacks of success in actually achieving interoperability through between the healthcare providers and the health information system they are using. So it's not only to support patient empowerment, it's also because in the Netherlands, it has proved extremely difficult to enforce interoperability between the systems of healthcare providers. In the system, quite a lot of money has been injected. Since 2017, the Ministry of Health is funding the acceleration program for information exchange with mixed results. So yes, interoperability profiles have been implemented, but they are not used as much as they could be. We have an e-prescription, yes, but it's not deployed through a unique central system. And thus, it's not yet fully used to its full potential, especially from the hospital level today. So although we have a very fair degree of electronic information capacity from the GP level, which are using still 8 different EHR solutions, there's been a consolidation here, but we are not at all in the same situation that in Catalonia with one dominant system. We have 8 systems. We're coming from 15. And in the secondary care, we also have a wide diversity of solutions, but with, however, one dominant system, Chipsoft, a private company. But the major are also present, clearly, as we will see in the next slide. One thing which is important is that many hospitals are today reluctant to adopt solutions coming from abroad because in the past there's been many experiences which proved not to be adapted to the Dutch context. So they accept, of course, foreign products, but they want to show that they understand how the Dutch context is functioning. Interoperability between EHR is still not officially thus regulated. We have official promotion of standards, but they are still competing with local or proprietary ones. We have 4 types of data which are shared through the national contact point infrastructure called the LSP. There's been a basic data set which has been defined and is mainly used for out-of-hour services. And other data, such as images, today are shared through separate networks, such as the network of IHE XDS network. So if we go on, I just mentioned it, the patient empowerment is a priority with MEDMA initiative created in 2015. I'll come back to that. What is interesting is that now we have, again, a new bill in preparation. So some 15 years later, coming with, again, now a mandatory electronic exchange of patient information between providers' information. So actually, the ball is coming back to where it started, with 15 years in between, with very mixed results, and that's a good lesson. We'll see that. There's been a specific initiative which is interesting called data registration at the source, which actually support organizations who want to better exploit and reuse their data. So that's they call that the clinical building blocks, and that was very innovative in the way that was a support for the developers of EHR solution in hospital in order to conceive their solution in such a way that from the start they would be as generic as possible. And they invested a lot in semantics, which is a key enabler for the future use cases, with a national terminal server, which has been made available to all the clients in the system. And finally, since 2015, we have an initiative which drives the data for research. Let's go back to that's a summary which takes everything I just mentioned. So I will not go there into detail. I just commented. Just here you see for the shared EHR that it's complex. You have one system for e-referral for from GP to hospitals. You have the national contact point where you exchange certain kind of data, and you see that on the right side. You have the regional network which decide which data and how and in which circumstances they want to share it. You have a system for the exchange of images, and you have also proprietary networks which have their own objectives. On the interoperability layer, actually, they have to deal with legacies, as they had first EDIFACT, which is a very outdated standard that's still maintained because it's still used. but they are trying to cope as everybody with the new key standards, and FIRE is clearly the one they promote now with MedMay in particular. But they also go on with HL7, and they for the infrastructure, as I said, they try as much as possible to rely on the IHE specifications. They have developed a lot in terms of semantic and the so-called clinical building blocks that I just mentioned, which unfortunately have not been used as much as they could by the hospitals, and so that's not a total failure, but at least that's a mixed success, because they only implemented only very partially. So if we look at the infrastructure today, we would say that there are two kinds of infrastructure in parallel. One which is national, the national switch point, which with one system, 44 regions managed just by a private organization, a foundation, where 20 umbrella stakeholders organizations are represented, with a good coverage, 90% coverage, with a limited number of data. And then you have regional collaboration organizations called RSO. We have 9 regions today who have developed such an RSO. That's 9 different systems. They are funded by the hospitals plus subsidies from local government. And they can develop, I would say, the use case they want, which are supposed to be more rooted in the regional reality. As a rule, in here, the healthcare provider can only share medical data within their region in those RSO, except the hospital, where they have the possibility to request data throughout the whole country. Quickly, who are our stakeholders in Holland? And we have more actually than in Catalonia. I'm really sorry for that. So as you already understood, the Ministry of Health, Welfare and Sport is there, first of all, to inject resources and money and support, and give the impetus, basically made in so that governance exists, but they don't control it. So that's the Information Council. I will come next upon afterwards. We have the National Healthcare Institute, which is important mainly in terms of the EHS policies linked to data reuse, but again, supporting it rather than managing it. NICTIS, just the National EHS Competence Center, which has an absolute essential role in terms of standards, but also implementation of standard compliance testing tools, guidance, training, and the payers. That's a difference also with other countries. Actually, we don't have one national insurance institute in Holland. We have 5, and they compete, and they actually can contract. They are free to contract because the healthcare providers, provided they respect the rule, but they cooperate under 2 different schemas for all the data flows related to rights and cost claims. They are the ones today who financially support the national contact point. And again, they created a specific foundation, and they can decide what they want to support, which initiative. They want to support a RSO or a private network, they can do so differently. So it's very competing. VZ, I already explained, is the organization which manages the national contact point. The MedMay Foundation, for the PHR, is again a different initiative. So that's a foundation, just completely under private law, which include national organizations of patient and healthcare provider. Here's RRI Foundation, again, completely private. 70 organizations, research institutions, universities involved in research, and also private partners, of course. DRSO networks, just a voluntary network of healthcare providers at regional level. We have OIZ, ICT Vendors Association, on a membership base, very much involved in the standardization discussion. We have, as I said, a number of private networks. We still have a key role because, for example, there is not yet an official e-messaging system offered by the authorities, that it's not allowed actually to do so by law since 2018. So private networks are still competing, and they develop, of course, services which are attractive but compete. And some of them are connected to the LSP, some not. The cooperative subdomain said is the provider of referral service from GP to secondary providers. You see, you have the Association of Municipalities, which are essential for social care, the Ministry of Interior for responsible for identification and non-identification workflows, and we will see that it's not the best they have done. The Dutch Data Protection Authority, of course, the Inspectorate General for Healthcare that I already mentioned before for the quality and safety of care. And finally, the Center for Information Cybersecurity in Healthcare. So you have an idea of a very liberal system, very competitive system. Now, how are we managing that? Actually, as you see here, Holland has created a national eHealth information council. And it's not a public body. That's, again, a body made of a representation of most of the stakeholders. And this National eHealth Information Council, we'll see its composition just afterwards, is supported through a number of bodies, other bodies. And the originality in this system is that it's a mix of representative of umbrella organizations and individuals. For examples, here in the architecture board care, you will find individuals which don't even need to be part of the healthcare system, but they need to be recognized for their skills, their competencies, their experience. So they act on their personal level, while all the people who make proposal here in the architecture care are more representative of the standard development organization active in the Netherlands, I will see. And so that's very much a mix of those two. We will see in a second another example of how Holland tries to involve individuals and not only organizations in the system. But they all can just provide solicited and unsolicited advice to the National eHealth Information Council. And we have, of course, is also the security and privacy expert community, but that's employees of the members of the Information Council. So that's the same people who actually work specifically on those issues. Let's have a look at who are there. So the Information Council is core group. That's basically the monitor of the eHealth governance in the leader, I would say, of the eHealth governance in the Netherlands. It sets the course, the path for both the acceptance of new use case, new building blocks, new funding schemes. So that's where basically all the key aspects supporting eHealth are discussed. And that's a public-private governance council. It includes 18 stakeholders umbrella organizations. It's indeed chaired by the Secretary General of the MOH. And the MOH directors and the CIO are also present, but they have no voting role. They are there, they're chairing, but they don't vote, actually. And as you can see, they meet 5 times a year, but the core group prepares, of course, all the decision and the meetings, meets 10 times a year. And you have basically all the organizations representing all the healthcare providers, physiotherapists, GP specialists, university hospital, private hospitals, integrated care organization, mental care, name it, it's there. There's just a look at the architecture board care and architecture community care. How does it work? We have 18 members, thus they work in their personal capacity, and thus they assess the proposal of the experts, coming thus from the architecture community care, who are then more people who are coming from standard organization, but also the people who are consuming standards in the system. And they are working on advanced analysis, and they are organized in specific working groups. So the framework of standards, care, address information security, data exchange, and so on. If you look quickly at the other expert groups that I just mentioned, the community standardization care is chaired by the eHealth Competence Center by NICTIS. And as you see here, you see standardization body, public bodies. So again, they are there, but no, or as always, they as in an observatory role. And they are the one who propose basically new standards or new adaptation of standards. And they have also a role of overview, so they constantly monitoring. The community of data expert healthcare is then chaired by another public body, the National Institute for Health and Environment. And then we have 25 different bodies. I call them bodies because sometimes it's public institutions, sometimes it's healthcare providers, umbrella organizations, sometimes research centers, sometimes it's insurers. So all the people basically interested in secondary use of data, and they deal with all the questions linked to registries, harmonization, data quality assurance, data reuse, technology for data reuse, and so on. This one is interesting. The chief experience CEO board, because that's the only one which is chaired, except from the National Information Council, of course, but in terms of group by the MOH. And that's again the second group where individual people can actually voice their proposal. And the MedMay initiative, actually, which was created in 2015, came from ideas which originated from that board, so which collected ideas from individuals who had good ideas, and this body, this governance body, is there in order to make new ideas to mature, and for the MOH then to propose it and to frame it in a correct way. We have these two main, I would say, enablers in the system. NICTIS is a competence center, today funded by the Ministry of Health, Welfare and Sport, which is a private sector organization. So it's also a foundation. Everything is foundation almost in the Netherlands, and which is the task primarily is creating standards for the flow and exchange of data, and which has also a supervisory body, which again represent industry, research, and healthcare providers. So you see, it's very much at all levels. The stakeholders' involvement is in almost all bodies. And VZVZ, which I already presented, which is funded by the insurance providers. So it was not, as you say, the LSP was not initially funded by the insurance, but it was since 2011 decided to transfer it to them. How do they work? But that's an association, so that it's made of umbrella organizations, and one of the key issues is that those organizations actually can discuss for ages, but they have absolutely no authority over their members. So as you can see, we had 4 associations. It grew to 10 plus 1 organization, but there is not an immediate match between VZVZ and the organization present in the National Information Council that I just presented. What is important is that's basically where VZVZ is a place where agreements are made about the financing of National Street Point, and where the people who want to connect get a contribution to the cost of connection. So there is a way to incentivize financially all the organizations who want to connect to the national switch point. MedMay, in terms of governance, is again a foundation. Thus a private organization. It aims, and it's very original, because it's not like the usual PHR. It's basically how to connect all possible solutions in such a way that the patient has a control over the data it generates. And thus it had to go with an idea where it puts the pressure actually on the developers themselves, which can get the label. And we will see that the MOH has put money behind that, of course, to incentivize all that. And it creates what they call a personal health environment, which can be an app, a website, which makes available data coming from many different solutions. Some are the service provider oriented, some are healthcare provider oriented, some are more patient applications, but they need to comply to many rules, to information standards, and they are guided by a number of persona. So it's funded by the MOH and the insurer. So you see here that the key funders are united to fund the system. And if we see how it works, we have an owners council with a 50-50 representation, so of patients one side, healthcare provider the other side. Then we have two directors, again, one from each side. And all the people who got the label, of man-made are part of the participant council, which is an advisory role towards the owners council. And when we see how it works, actually, NICTIS is again the one which makes the things possible, because they analyze the compliance, the possible compliance of the solution with the rules. VZVZ is the one which validates actually the solution, and the final decision is taken by the board. So actually, it's again a way to respect the decision of 2011. How do they plan and strategize? So I already got to many things into that. So I will only just summarize here, saying that the big lines are more provided by the Ministry of Health, but really only as far as health and e-health is connected, I would say, and making sure that sufficient funding is going to be made available, and the global transversal orientation. But the eHealth Information Council is really the one which is responsible to translate those orientations into concrete proposals. NICTIS is the one which then takes those priorities and translates, at least from a technical level, into a number of concrete developments. Not alone, but not alone, because there are some building blocks that they cannot do. I will come back to that, like the authentication and identification layers, for example. Then the regional networks can develop their own plans and may also request NICTIS to support them, and NICTIS does that. And as I already mentioned, the National Healthcare Institute is really the one who is supposed to support the development, segregation, use of data. Let's go quickly to how all this is funded. This NICTIS is fully funded by the MOH, which also funds a lot of other foundations. So the MOH is maybe not managing, but it's, as I said, supporting financially basically everything which is important in the system. The health insurers mainly fund the individual connection to the national infrastructure. The regional networks are mainly funded by the healthcare providers themselves, with possibly some additional funding, mainly from municipalities. The MOH just funds now an incentivization program, so since 2017, which is focusing on information between patients and professionals mainly. And it covers several domains, just exchange between hospitals, between the mental health care domain, between health general practitioner and themselves, and maternity care, just to name a few. And it was also connected now with the MEDMA initiator. So you can see that's not symbolic. They have been since 2017 funding several schemes, every time focusing on the different pattern of care with different standards every time. And as I said, well, they got some results, especially, but in terms of standard compliance, but it doesn't mean that it's actually used. That's one of the big problems. If we look at the healthcare providers level, they are also, like everywhere, investing in their own system with their annual budget, but they can receive financial incentives if they participate to specific programs. That's basically the point. Public funding is often used to answer other requirements. That's what we see we see that the hospitals are actually using the VIP program in order to deal with what they see as more urgent priorities than actually the compliance. So that's the money is not always used for what it is meant to be. That's the key idea. And just as
sorry, look,
yes,
to interrupt, I'm afraid that we are going to the end of the meeting. We have 3 minutes left. Can we summarize rather quickly and probably have one question from the audience? But yeah, probably not more. We can continue maybe discussion, but we should wrap up now.
Yeah, then I will go just to the last slide because I said it's extremely complex, so it's almost impossible to give an idea of how it was. So I would just like to finish with the success then. There's indeed a very active involvement, but maybe per default, I would say, of all stakeholders and a lot of expertise. There is a very interesting initiative in terms of patient empowerment and also in terms of infrastructure with MedMay. Public-private partnership, they know how it works. That's very clear. Excellent documentation of knowledge. They are testing incentivization packages, but there's still more work to be done. They have scalable infrastructures, but too many. And they have now a specific data infrastructure for research, but a separate one. What they need to improve is that the decentralized nature of health IT landscape makes it very difficult to get consensus of the services to be developed and who is authorized to run them. That's the major issue. So the link between policy and practice is weak. Critical building blocks are still missing, which is strange, like the healthcare provider address book or the patient consent central service or the identification and authentication services, for example, managed in a generic way. And there is a gap between the range of AI solutions on offer and the extent they are used. Privacy and security remain a major concern, and it's still blocking a number of developments. Business and technical orchestration is still very much partial, which makes it sometimes very complicated at the individual organization level. And as I said, there is now a political turnaround with a proposal because they just say that governance alone can be very, very wide and all-inclusive, but actually it does not succeed to enforce an interoperability framework, which is coherent and provide results. That's the big lesson we get from the Netherlands. So a lot of energy, a lot of competence, a lot of resources, a lot of foundations, but insufficient results in terms of coherence and infrastructure for advanced use cases.
Thank you very much. Very interesting. Deserves more time definitely to discuss it. But please, if any questions from the participants.
Name is Estonian Medical Agency. I'm just wondering whether you are trying to do some governance also on the information systems used in hospitals to make them to reduce the number of platforms or to do some governance there.
Yeah, but that's actually the situation they face today is that as competition is the rule, everybody is still trying to fight for its own network to keep the clients, basically. That's the big problem. So that's why they say they won't reach results only with governance and involving the people and anything they say. So that's why they want a law now to enforce interoperability between systems. And in order to say, well, yes, we need competition, but we have too much. And actually free market in a way is detrimental to governance, to overall governance. And they will not go, it's not going to be a fully controlled system, never. But it's clearly, and they want to do now with eHealth what they have done with health before. That's what I want to say. And they had tried to do it in 2005, but it was too early. Because everybody wanted to develop its own business level, and there were many ideas, and so they all complained to the parliament to block any legal initiative at that stage, And now, I mean, 15 years later, they can only say, no, we cannot go along with that. We need now an integrated and a common vision. I mean, the vision is nice, but actually, if we go on the same way, we won't succeed.
So at least you need a common vision and interoperability. So these are the goals.
Yeah, exactly. But there are too many competing standards. And as I said, it's probably the country, if you want to learn about standards, go to the NICTIS, to NICTIS. That's the place where I go when I want to know how what standards, what it is exactly, what it's doing, is it employed or not. It's very well documented.
It's really a question of leadership then, making a decision and pushing an action.
No, I mean, it's very true of what we have seen. I mean, I think the MOH have been trying to do everything they could, but were completely blocked by the decision of 2018. And they were attacked all the time, every time they would take a new initiative, by some people at the parliament to say that you are not respecting the decision. So that's where they were, basically, in terms of, and now with this new law, this new bill, and they have another problem because, for example, the National Information Council, which is really the core body, as you have understood, who's managing the eHealth governance in the Netherlands, that is really all-inclusive, is supporting the idea. And it's difficult because the evidence is there that they have not reached their objective. But when they come back to their members, the members go back behind and try still to amend the current law to try to decrease its potential. So it's not an easy one. But at least I hope you got the overall picture of what constraint, what were the constraints, what is the cultural background, how this is linked to the health system as such.
Thank you, Luke. It's a very colorful description of the situation.